So, good evening, everyone. Our respected Chairman, Sir, IAP NRC, and esteemed experts, Dr. C. Gauri Shankar, Sir, and Dr. Javed from Kashmir, and of course, who has been doing it the finest possible way, moderating this advanced pulmonology clinic for a couple of years, last couple of years. So, Dr. Kamal Kumar Singhal from Delhi, thank you so much for shouldering the responsibility again. And Dr. Kamal, thank you. And the presenter, the institute, Dr. Parma Chandane, the mentor and the presenter, Dr. Avantika, and all the dearest delegates from our EB, OB, and IAP NRC members and other pediatricians pan India. Thank you for being on this platform. And we are starting afresh in 2025, one of the most popular academic program from IAP NRC, the Advanced Pulmonology Clinic. And I'll just keep it short and pass on to my chairman, sir, for his welcoming address. The session. Thank you, sir.
Thank you. Thank you, Dr. Modi. Greetings from IAP NRC. A warm welcome to all respected dignitaries who are on the screen today evening. I welcome to you all to this first edition of Advanced Pediatric Pulmonology Clinic for 2025. As Dr. Modi has told you, this has been a highly successful program in the past 2 years. And we really thank all the participating institutes, the PG students, the fellows, and the DM residents who have taken active part in this program, and particularly the mentors who have excellently trained these young researchers and present excellent cases. And the program popularity has risen to great heights. It's very well appreciated. And I really like to thank to all the institutes and all the mentors. I'd like to thank Dr. Sabasankar, who is the fulcrum behind the success stories which we have won for this particular program. And we hope that he'll continue to guide us and steer this program in the same way as he has been doing in the past 2 years. Thank you very much. I'd like to thank all the students, all the DM residents who are going to be a part of the program. My request is that please take this program seriously, prepare these cases for these sessions very diligently, because we have got a very good viewership, and all the viewers, they look towards you for a detailed analysis of the cases and how to approach complicated pediatric pulmonology problems. So thank you again very much. To set the ball rolling, I'll again pass it on to Dr. Modi to start the session. Thank you very much, please.
Thank you, sir. So we'll straight away go to the academics and over to Dr. Kamal Kumar Singhal, our moderator permanent for this pulmonology clinic series. Over to Dr. Kamal.
Thank you so much, sir. Thank you. So we have today Dr. Parma Chandane as mentor, and Dr. Avantika Chauhan will be presenting. And we have with us the lead discussants. We have Dr. Gauri Shankar, who is currently in Mehta Children's Hospital, Chennai, but he has a very vast experience in pediatric pulmonology and a very respected pulmonology and pulmonology circuits. And then we have down south, so we go to the top. This is Dr. Javed Iqbal from Sher Kashmir Institute of Medical Sciences. He's additional professor there, and a lot of work on CF and very in-depth knowledge of pediatric pulmonology. So we have two leading experts here, and then we have Dr. Parmarth as mentor, currently in JB Wadia Hospital. So I think let us start straight away. I will request Dr. Avantika to share the slides and start the presentation.
Hello, sir. Am I audible?
Yes, you are audible. Please share the slides.
Yes, sir. So I'm not able to share the slides, sir.
Okay.
As a co-host, Sir Hassan to
Yes, you can do it now, please.
Yes, sir, I'm trying, sir, but I'm not able to share the slides, sir.
You can do it now.
So, if the support team is not able to help us in this,
Doctor,
what I suggest is,
try now.
No, I've allowed it.
okay,
So is my slides visible?
yes, it is visible and you are audible.
Okay, thank you, sir. Good evening, everyone. I'm Dr. Avantika Chauhan. I'm presenting a case which we have titled it as A Tale of Pneumonia. So this is a patient, 5 months old male child that presented to us on 3rd December 2023, is a resident of Ambernath, Maharashtra. Informant was mother and the history seemed to be reliable. He presented to us with the chief complaints of fever for 2 months, cough for 2 months, and not gaining weight for 2 months, along with increased work of breathing for the past 3 days. The history of present illness. So the patient presented to us with fever for duration of 2 months, which was intermittent in nature, low grade around 100 to 101 degree Fahrenheit, and was relieved by medications. He also presented to us with a history of cough, which was present for past 2 months, which was insidious in onset. It was dry initially. Now it was wet type, gradually progressive, non-spasmodic, relief by nebulization, but later there was no relief by nebulization. There was no aggravating factor, and it was not associated with feeds or post-acid vomiting. The mother also complained of not gaining weight for the past 2 months, along with increased work of breathing for the past 3 days, which was gradually progressive and associated with coughing. The antenatal history was uneventful. There was antenatal scans were normal. Birth history was 2.7 kg birth weight, a late preterm, LSCS in view of leaking per vagina. First in birth order, born of non-consanguineous marriage. Postnatal history was uneventful. There was no history of NIC hospitalization. Was asymptomatic till 3 months of age. Feeding history, he was on exclusively breastfed, immunized till 2.5 months of age. And developmental history, he recognizes mother, social smile was present, and neck holding was also present. They belong to lower middle socioeconomic class. Negative history. There was no history of delayed cry at birth or an ICU admission requiring oxygen support. There was no history of suck cycle, feeding diaphoresis, bluish discoloration of skin to rule out any congenital heart disease. There was no history of noisy breathing. There was no history suggestive of regurgitation of feeds, coughing after feeds, or difficulty in feeding, suggestive of any aspiration syndrome. There was no history of oily stools, salty kiss, or delayed passage of meconium to rule out cystic fibrosis. There was no history of delayed fall of umbilical cord to rule out immunodeficiency. There was also no history of persistent rhinitis, recurrent ear or skin infection to rule out primary ciliary dyskinesia or any primary immunodeficiency. There was no history of recurrent nebulization, no history of biomass fuel smoke, cigarette smoke exposure, or any scented substance exposure. There was no history of exposure to pets or pigeon, and there was also no history of TB contact. So this is the pedigree chart, and there was no family history of any allergy, asthma, rhinitis, or TB in family members, and no other similar complaints in any other family members. The significant past history is present. The patient was first admitted at the age of 3 months with history of fever for 5 days, cough for 2 days. The duration of admission that time was 15 days, and he was treated with IV antibiotics. Then the patient was discharged, but he was not completely asymptomatic. Cough was still present, which increased at the time of second admission, which was at the age of 4.5 months. So cough was present in the past admission, and he again developed fever for 3 days. This time, the duration of admission was 5 days. He was treated with IV antibiotics and was provided with oxygen by face masks for 1 day and nebulization. So this is the timeline of the patient. He was asymptomatic at birth. Then at 3 months, he developed fever and cough, for which he received IV antibiotics. Then cough was still persisting in between the first and the second admission, which had increased during the second admission, and fever was also present. So during the second admission, he again received IV antibiotics along with nebulization. He was not completely asymptomatic, and when he presented to us at the age of 5 months, then he had fever and cough. So I would like to summarize my case as a 5-month-old male child, first in birth order, born out of non-consanguineous marriage, late preterm. Antenatal and postnatal history were uneventful. No history of NIC hospitalization. Presented to us with fever off and on for 2 months, cough gradually progressive for 2 months, not gaining weight for 2 months, and increased work of breathing for the past 3 days.
Thank you, Dr. Avantika.
Yes.
I think the stage is set now. So we have a young infant with this complaint. So I'll first come to the lead discussants. We have Dr. Gauri Shankar with us, just so that we have a 5-month-old child, third admission, and with this history, sir, any clarification that you wish to seek or any comment that you wish to make?
Is the mother looking normal or undernourished?
So the mother was looking normal, sir.
Okay. In the history, was there any sibling death or early infancy deaths among the relatives?
No, sir. No such history was present, sir. This was the first born, and there was no history of any abortion.
And was any antenatally detected lung malformation in any of the ultrasounds?
No, sir. As far as the mother, she had followed up antenatally, but she said that there was no such thing was told to her.
How was the mother's milk intake? Was she avoiding milk or was she on like cow's milk or any other milk? Was the mother like milk-free diet? Any history regarding that?
No, sir. Mother was taking normal diet, sir.
Including milk,
including milk. Yes, sir.
Okay. At any time during the cough, was there apnea?
No, sir, there was not apnea, but there was increased work of breathing.
And is the child appearing blue at any time during the cough episode?
No, sir.
Okay. And is the child's voice normal or feeble?
So no changes voice, sir. The cry was, the mother said that the cry is same since birth.
Okay. Why did the mother say poor weight gain? Was she that intelligent to find out every month whether the child is growing or
So she told that
not? Is it delay like slow weight gain or no weight gain?
So the patient was admitted for past 2 months. So the mother was saying that the baby is not gaining weight for the past 2 months. And before that, before the first admission, he gained some weight. And after that, for 2 admissions, she observed during the first, second, and the third admissions that he has not gained any weight.
Because the child has been sick, has the child received any vaccination, including 0-dose polio?
So he has been vaccinated till 2.5 months of age, including polio.
Okay. At any time, has the mother noticed?
Avantika, keep your screen on.
My screen
Has the mother noticed difficulty in washing the stained cloth of stool?
No, sir.
Any offensive odor in the stool?
No,
Was
sir.
there any increased frequency or decreased frequency in stool?
Sir, as such, it was not reported by mother, sir.
The first admission was for 15 days.
Yes, sir.
Has the mother been informed of any problem? Because first time itself admission 15 days.
Yes, sir.
Like everyone would have been first child, everyone would have been inquisitive. So has the mother been told of any problem to the child, or they said everything is
So mother was not
fine?
informed about any problem for the child. She was just saying that baby's cough was not resolving, and fever was also present during the first admission. So they were giving IV antibiotics for the same.
Has the mother noticed any increase in pallor or becoming pale over the period of last 2.5, 3 months?
No, sir.
Any blood streak in stool?
No, sir.
Incessant cry in the past 3 months?
No, sir.
Dr. Avantika?
Yes, sir.
Incessant cry in
No,
the
sir.
past 3 months.
No history suggestive of the same.
Okay, I'm done.
Thank you so much, sir. I think a lot of ground has been covered. I think my doubts have been cleared by Dr. Gauri Shankar himself. And now, Dr. Javed.
Yeah, I'll come briefly. Dr. Avantika, I just want some clarification. Was the cough predominantly wet or predominantly dry cough?
So the mother said that initially it was dry, but later on, during from the next admission, second admission, she started to notice it was wet.
Okay. Was there any history of salty kiss?
No, sir.
Was there any history? What about BCG scar? As per history, was BCG scar as per mother normal, or there was, some pus coming out of BCG scar,
So BCG
or
scar,
some swelling around axilla or neck?
it was normal, sir.
Okay. Any family history of tuberculosis?
No, sir.
Any history of oral thrush resistant to treatment?
No, sir.
No. Yeah. So any history of BRUE?
No,
BRUE?
no, sir. No history of BRUE.
Okay. So any history of foul smelling stools?
So no history of foul smelling stools, bulky stools.
Okay. So last question, any history of choking while feeding? You said that choking after feeding, there was no history of choking after feeding. Any
No,
history of choking during feeding, at the time of feeding?
no, sir.
Okay. That's it. These were some queries.
Thank you, sir.
Okay, thank you. You can carry on.
Thank you, Dr. Javed. Thank you so much. So the question here that comes up is, to me, if a 5-month-old child has this third episode of pneumonia, the first thing that comes up is it an acquired kind of a problem, or is it congenital? This is how probably I would start thinking of, as Dr. Gauri Shankar has looked for features of CF. When we, in your negative history, I think the frequency of stool was missed. You talked about oily stools, but how many stools per day? It was probably not there.
Yes, sir.
So that is one way to think of it. Then
Yes.
are important in that sense. So Dr. Harishankar, what do you think? Can it be something like pertussis at this age?
Pertussis unlikely to have gone on for so long, which is what to say, like leading on to undernutrition and 15 days hospitalization. Child would not have become better for them to send out, because it would have been, the cough would have been progressive. The parents definitely would have stayed there rather than go home. That is number one. Or probably like what I was thinking initially at 5 months, whether it's a congenital lesion which is presented with an infection at this point of time. CPAM getting infected, CPAM sequestration getting infected. Then number two, anything to do with aerodigestive tract anomaly, because she said there was no choking, there was no cough during feeding. Probably least possible H fistula. Okay, that is the least possible that has gone into the background, because there was no cough while the child was feeding and after feeding too. And it did not start on day 1 to till day 60 or day 90 when the child got admitted on third month. So probably a connection between the esophagus to trachea probably appears remote. But if there is going to be anything above near the larynx, a laryngotracheal cleft, getting into an aspiration, increasing severity, probably yes. That is one more, but these are all possibilities. But because everything happened in a completely breastfed child, first baby, is there anything to do with cow's milk protein intolerance? Probably here, the stools may have been like frequent. Probably child would have become pale. Probably like child can have even like bleeds, intrapulmonary bleeds also. But child will be becoming pale, undernutrition, cough, which will not settle down. The radiological clearance may not be there. So this is one aspect. But the national disease, TB, because cough for more than 2 weeks, not gaining weight, with fever intermittently, probably like I need to think of that also. In South India, I will always ask for a history of a bad child rearing practice, because aspiration, they blow oil into the nose, into the mouth, they put the finger inside the throat to clear whatever they had put inside the nose, so that child gags and has oil inside the trachea and leading on to pneumonia, which takes it's a lipoid pneumonia, which takes a long time to settle down. And the child is neurologically normal, development is normal, so the like chance for aspiration, either cricopharyngeal aspiration or aspiration from below, slightly on the lower side. So still like I'm confused. I have many possibilities. I will want physical examination, only then I will be able.
Thank you so much, sir. Thank you. I think most of the queries that are there in the chat box have been answered in this discussion. There is no delayed cord fall. There is no history suggestive of immunodeficiency as such, no blood transfusions, nothing to suggest pulmonary bleeds. There are no spells, blue spells. And the overall picture is not suggestive of pertussis. The fact that I said pertussis, it is for the audience. This is a very, very remote, unusual possibility. This is not how we usually think. We think common first. And as Dr. Gauri Shankar said, that 2 months fever, we would probably think of something like tuberculosis as more. There's a febrile onset fever which is going on. So think of common first. So let us look at the differentials that the treating team has thought of, and then we will come after the examination, we'll have a discussion again.
So we kept our first differential as congenital lung malformation with superadded infection, as the patient was having fever for 2 months and cough for 2 months. Although the patient had, mother said that she had normal antenatal scans. Second possibility we kept as tuberculosis, just because he was having fever and cough for 2 months and was not responding to treatment, along with not gaining weight, but there was no history of any TB contact. We kept a possibility of cystic fibrosis because of an early age of onset and past hospitalization history, along with recurrent cough, which was initially dry and now had become wet and was also not responding to nebulization. The frequency of stools were normal, and there was no history of oily stools or salty kiss or bulky stools. We also thought of primary ciliary dyskinesia, again due to same findings, but there was no history of any NICU stay or any history suggestive of congenital heart disease, and there was no history of persistent rhinitis. We kept a possibility of immunodeficiency, primary or secondary, owing to the early age of onset and not gaining weight and symptoms which was present for past 2 months along with recurrent respiratory infections. But there was no history of HIV in the mother. There was no history of recurrent staph infections or abscesses, rash, or any other organ involvement or sinus infections. We kept the last possibility of interstitial lung disease because the patient was having persistent respiratory symptoms, which was not improved with nebulization, and was also having not gaining weight. Points against was there was no family history of similar complaints.
Thank you, Dr. Avantika. So we have had a discussion about these differentials. So we'll, after the examination, we'll again have a look at the differentials, and then we'll come back to the lead discussion. Let's proceed with the examination.
Yes, sir. At the time of examination, the patient was afebrile. Heart rate was 123 per minute. Respiratory rate was increased, that was 64 per minute. The saturation was 99% NIV RAMs. The CRT was less than 3 seconds, and pulses were normovolumic, regular, and all peripheral pulses were palpable. During general examination, mild pallor was present. There was no icterus, clumping cyanosis, or edema, no dysmorphic facies, no lymphadenopathy. BCG scar mark was present and was normal. On anthropometry, the length was between -2 to -3 standard deviation. Weight was less than -3 standard deviation. Head circumference was also less than -3 standard deviation, and weight for length was less than -3 standard deviation. Suggestive of low birth, failure to thrive. On upper respiratory tract examination, on nose, there was no discharge, bleeding, or any evidence of foreign body. Ear, there was no discharge. Throat, there was no redness, discharge, or whitish membrane, or any findings suggestive of oral thrush. Lower respiratory tract examination or inspection, bilateral chest movements were equal. There was no sinus, fistula, or scar marks on the chest. No suprasternal retractions, although the patient had mild intercostal and subcostal retractions. Apical impulse in the fourth intercostal space was visible. Spine and vertebrae were normal. On palpation, the findings of inspection were confirmed. Trachea was central in position. Respiratory movements were equal in all the areas, and apex beat was present in the left fourth intercostal space medial to the midclavicular line. On percussion, bilateral resonant note was heard in all the lung fields. On auscultation, we noticed bilaterally reduced breath sounds in all the lung fields, and there were no adventitious sounds. Rest of the systemic examination was normal, although the child was lethargic because he was an NIV. I would summarize my case as a 5-month-old male child, firstborn of non-consanguineous marriage, late preterm. Antenatal and postnatal history were uneventful and no history of NICU hospitalization. Fever was off and on for 2 months, cough gradually progressive for the past 2 months, not gaining weight in the past 2 months, and increased work of breathing for 3 days. Past history of hospital admission 2 times, required nebulization once. No significant negative history. And on examination, there was increased respiratory rate with mild intercostal and subcostal retractions. Saturation was 94% in NIV RAMs with bilateral reduced breath sounds in all the lung fields.
Yes, please proceed with the differentials.
So now after the examination, I kept my first differential as congenital lung malformation, superadded infection. Second possibility of tuberculosis was kept. After the examination, I had kept interstitial lung disease as a third possibility, which was initially I thought as a last possibility, because the patient was having hypoxemia and retractions with failure to thrive. Although there was no family history suggestive of any member requiring oxygen in the past. Next, I had kept cystic fibrosis a little down, followed by primary ciliary dyskinesia and immunodeficiency.
Perfect. So now I think we have had our history and examination with us, and again we will come back to our lead discussants. First, I will again request Dr. Javed. Dr. Javed, anything that Dr. Avantika, please show the slide of your differential diagnosis. Dr. Javed, anything that you wish to comment on? Would you differ with the differentials that have been considered here?
What was the reason? Why did you keep congenital CPAM first possibility? What was the reason? What were points in favor of this, keeping this as first differential diagnosis, and what were points against? And you have
so
mentioned
Avantika, whatever you have written. Other than that, do you think there is any strong pointer for a congenital lung malformation?
So I could have kept tuberculosis as first and congenital lung malformation as second. So that could have changed. Apart from that, there is nothing as a very strong possibility suggestive of congenital lung malformation. But tuberculosis could have been kept first.
See, congenital malformation, your antenatal ultrasonography is normal. I mean,
yes,
it is sensitive. It is a very sensitive test for CPAM or any other congenital lung malformation. That is normal. And why you have failure to thrive? I mean, your weight, baby's weight is less than 3 standard deviation.
Yes.
So why so much failure to thrive? which is not explained by the secondary infection of CPAM or any other malformation. So that is why I was, little bit, I would not keep this as first possibility,
Yes,
based
sir.
on your history and examination, based on antenatal scans, based on weight and thermometry. And why did you keep cystic fibrosis as the fourth possibility? I am able to see your differential diagnosis, but why just based on absence of oily stools, you have kept this as fourth differential diagnosis? Why not to keep this as first differential diagnosis?
So first differential diagnosis, so there was non-consanguineous marriage, and patient was well till 3 months of age. Apart from that, there was no response to IV antibiotics, and I would have kept it as maybe a second possibility, if not the first, after tuberculosis.
I mean, there is severe failure to thrive. There is
Yes, sir.
recurrent pneumonia. There is chronic wet cough. What else do you need to keep this as first possibility? Just the patient is non-consanguineous marriage, which we see now.
Yes,
Very
sir.
often we see that even parents are not having non-consanguineous marriage, and we do see CF. I mean, we have conducted pan-India study, and we
Yes,
found
sir.
that majority of patients, up to 70% of patients have non-consanguineous marriage. I mean,
Yes,
that is
sir.
supported by Western literature. I mean, just absence of, you have kept. And why did you keep, where is PCD, primary ciliary dyskinesia?
So I kept it after this cystic fibrosis.
So, so why?
I was expecting in this patient, if the patient is of CF or primary ciliary dyskinesia, reduced breath sounds were present, and retractions can also be present in both the conditions. I was also expecting some adventitious sounds which could have been present but was not present, and there was only reduced breath sounds were present. Creps I expected, which was not there. So I thought if maybe it is less, I thought it to be less likely.
Okay. So why did you keep DLD as your third possibility?
So DLD I kept as a third possibility because the patient was for the past 2 months here, the main complaints was of cough, which was initially dry. The mother said that it was always dry cough, and
And
now
you said, but you said wet cough.
so initially it was dry, which has now become wet.
Mm.
So patient and was also, now he had retractions were present and hypoxemia present during our admission, although there was no documentation of such in the past. So therefore I thought that any patient who is presenting with cough retractions can also be, although DLD is rare as compared to cystic fibrosis and PCD. So therefore I thought I should keep it as a third possibility.
So when patient was admitted, he was admitted as an acute case.
Yes, sir.
And you don't know the past history, what was oxygen sat at home in last 2 months.
Yes, sir.
Even if there would have been history of persistent hypoxia, chronic hypoxia, I would have definitely kept this as possibility. But patient has presented to you acutely with
Yes,
retraction and hypoxia. These are cardinal symptoms of any pneumonia. So
Yes.
if there would have been history of chronic, persistent retractions for weeks, as well as hypoxia, then this was important possibility. But based on your admission finding, I don't think we can keep this as possibility.
Okay.
Anyway, these were my queries.
Thank you so much, Dr. Javed. Thank you. So this is why we have lead discussants from such very different geographies. You have kept a list of 6 differentials, but the most important factor that decides which one will be the first differential and which one will be the last is epidemiology. So when Dr. Javed's who practices in Kashmir thinks of differentials, he will think of differentials which are more common. They are like cystic fibrosis and all those things. But yes, I do agree that interstitial lung disease, hypoxia is primary thing that should come up, clubbing, hypoxemia. But then in a child who is is still not yet 6 months of age, where we keeping a high index of suspicion would not be bad, because in between there are periods where he has not been monitored. So if somebody thinks of an ILD, he will not at least miss that. But yes, we do not upfront have reasons. But I think the possibilities like CF and the other things that you have kept very well taken. But I think a lot is governed by what we usually see in our practice. And now let's come to Dr. Gauri Shankar, sir. So what would you think of in your place?
Child comes with hypoxia and congenital lung malformation probably usually does not lead on to that severe malnutrition. The weight was less than -3 sp. So this will not come into my picture, congenital lung malformation. Number two, in your general examination or your system examination inspection, was there any Harrison sulcus? Did you look for? Was there anything? Because child is so malnourished?
No, sir, there were no features suggestive of rickets.
No. Harrison sulcus.
No, sir.
Because the child has been having cough, probably increasing respiratory rate, and the respiratory muscles are using whatever nutrition the child is getting. I will expect the diaphragm to keep on working more, and by this time I will expect a Harrison sulcus. Okay, fine. I will keep interstitial lung disease, whatever may be the cause, as the first possibility, because it is a diffuse problem, like maybe CF, that also is a possibility. But for me, I will look at interstitial lung disease. Then I will think of an immune deficiency, and this also will lead on to like failure to gain adequate weight and symptoms not fully resolving, even though we don't have a telltale evidence till now to say that it can be a primary immune deficiency. Third, CF, then TB, all these. But I won't keep congenital lung malformation at this point of time, even though I started with congenital lung malformation during my initial phase.
Yes, sir.
Thank you, sir. Dr. Avantika, please proceed.
Yes,
So
sir.
as we have just seen, CF is there in everybody's mind, and you can always have CF without GI manifestation. You can always have CF when they present very early, something like 3 episodes of respiratory distress. So it should always be considered. But I think both the experts also agree that congenital at this time, when for the first 3 months the child was well, thereafter there is a persistent kind of a symptom for 2 months. Maybe it can come down a bit lower. But
Yes,
let's proceed. Let us see. Let us go to the investigations then.
okay, sir. On blood investigations, we found that there was leukocytosis, neutrophil count was raised, and there was also CRP was also raised on 2 occasions, which was suggestive of some infective process that is going on in the body. The ABG at the time of admission was almost normal. Later on, when it was done, when the patient was on mask, was suggestive of respiratory alkalosis. The other investigations that we did were the blood culture, which was done 2 times, there was no growth. Urine culture was no growth. To rule out TB, we first did a gastric lavage gene expert, which was negative. Adenovirus quantitative PCR was done, which was negative. EBV quantitative PCR was also negative. The HIV, mother HIV PCR was negative. Immunoglobulin profiles were normal. NBT DHR was done to rule out immunodeficiency, that was also normal. And to rule out any congenital heart disease, 2D echo was done, that was again normal. So radiological investigations. So this is the first X-ray which was done outside on 11th March 2024, which is suggestive of the trachea is central in position, and we can see that there is consolidation involving the right upper lobe and right middle lobe with air bronchograms, along with consolidation present in the left middle lobe lingular region with air bronchograms along with the left lower lobe.
Oh, this is a interesting X-ray. So, are you sure, Dr. Avantika, that this is a consolidation, and what are the reasons for that?
Sir, we can see air bronchograms which are present.
Okay.
So that is one finding suggestive of consolidation. Apart from that, collapse is also present. So because there's some pull is present of the left upper lobe, there is some degree of hyperinflation is also present in this.
Perfect. Dr. Gauri Shankar, anything that you wish to comment on this radiograph?
The first picture, 11/3/2024, has bilateral hyperinflation. The domes of the diaphragm are flat. The right upper lobe, yes, I will agree, consolidation. There is right middle lobe, and left side, you don't have a middle lobe. We call it as lingula. Yes, there is an issue in the lingula. And in the second X-ray, the consolidation, like 4 days, we don't expect the radiological clearance, but there is no worsening. The first X-ray was over-penetrated X-ray. The second X-ray, yes, the X-ray has got a normal penetration. I don't see much difference. And probably I will just put this as involving both sides, both lungs, probably like a bronchopneumonia picture. Rather than the cardiac silhouette, I'm unable to make out clearly. So at this point, nothing in heart, but everything in the lung.
Thank you, sir. Dr. Avantika, why can't it be a thymus?
Sir, it can be a thymus, but till this big thymus, as I have not seen, so involving the entire right upper lobe.
So many of us are yet to see a lot in our lives. So there are objective reasons why you would not consider, like you said, air bronchogram.
Air bronchogram, yes, sir.
That will not happen in a thymus. Otherwise, usually see such a well demarcated lateral edge. It is usually not so common in a consolidation alone. It can happen in collapse consolidation because that horizontal fissure, if it is pulled up, it can give that picture. Otherwise, a very sharp horizontal lateral border takes you towards thymus. But in this particular case, there is a pull of structures towards this lesion, and there is an air bronchogram that makes us think that this is a collapse consolidation, not just consolidation, a bit of volume loss also. So, Dr. Javed, anything on this radiograph if you wish to say? Otherwise, you'll go to CT scan.
I think it has already been discussed. One thing only, that it has involved multiple lobes. That means it is involving the systemic, lung involvement, not a particular lobe. So we have to think of some local defect in defense mechanism as well.
So just one question: in our hemograms that we had, the TLC was very, very high.
Yes, sir.
Even the lymphocyte count was very, very high, and one of the ABG showed BICA very, very high. So, Dr. Vandika, how would you explain that with?
So the ABG, one ABG, that was a mixed venous gas, was having a BICA about 28.6. That time the patient was having a lot of respiratory acidosis.
Okay.
So
and the blood, yes.
So the blood picture, so we were suspecting some infective process going on, although the lymphocyte count was not explained. The TLC was that neutrophil counts were explained, but high ALC was not explainable in this.
Okay, fine. Okay, fine.
One finding that platelet count is very high in third CBC.
Yes, there is
how can you-
thrombocytosis also.
Thrombocytosis was also present, sir.
So how can you explain this thrombocytosis?
So
This is a finding.
yes, sir. So we were expecting it may be all due to some inflammatory process that is going on.
Chronic inflammation, infection. Okay.
Dr. Gauri Shankar,
Can I come in?
Yes, please.
Okay. Was any stool examination done? Occult blood, stool occult blood,
No,
fat
sir.
globule?
So we didn't do a stool examination of this patient.
Throat swab.
Okay, fine.
Any throat swab for culture? Any pseudomonas growth.
So I'll come to that, sir.
Okay. Okay.
So let's proceed, I think. Yes.
So these are the first two X-rays. Subsequent X-rays done were also suggestive of similar picture, although at the time of the time of presentation to us on 4th May 2024, we could see that there is increase in the consolidation in the right upper lobe with air bronchograms, and also then the left lingular region. We could also see some area of hyperlucency, which is present in the center of the mediastinum, suggestive of some air trapping.
Okay, please proceed.
The next two X-rays was done were similar in picture, which was done on 7th May and 9th May. During this time, we did a ultrasound chest.
Just a word about this radiograph, the last one.
Yes, sir.
Now on the, if you see somewhere in the center itself, there is a black shadow which is coming up.
Yes, sir.
Where the carina is. What
Yes.
can that black shadow be?
Sir, we were suspecting, is it because of, is it some air trapping that is going on in the patient, or is it some clearance, but clearance was less likely to happen because the patient's clinical condition did not improve.
Because in the second, the X-ray done on 9th of May shows that black shadow has increased further in size.
Yes,
So
sir.
either it is cross herniation from the other side or something else.
Yes, so that was also kept as a possibility, sir.
Dr. Avantika,
Yes, sir.
can we go back to the previous X-ray?
Yes,
Okay,
sir.
before that?
Yes, sir.
Okay. This right upper lobe or right upper zone, that shadow, just go to the next slide. This keeps on increasing in density and in size.
Yes, sir.
There is no mediastinal shift.
No, sir.
So it is within the lung, not outside the lung. And what is getting inside there is slowly increasing. And the border appears a little bit convex. So is there any fluid collection there? Because of the infection. And the counts are very high. White cell count is high, platelet count is high. The next X-ray, ma?
Yes, sir.
See here, almost it is something like a convex. It's
Yes.
fully homogeneous in the right upper zone. Some infection, probably I need to eat back my words, like maybe a congenital malformation getting into an infection, probably causing more distress, and child is not settling down with some aspiration either from below or from above. Like this is what I can make out from the X-ray. And because the trachea appears still, you are able to see the through and through right lower lobe bronchus or bronchus intermedius lower lobe. So something is not all right in the right upper zone. This may not be in the infection in the lung parenchyma, some congenital anomaly which is getting infected and not fully settling down with the antibiotics 15 days what the child had received. Probably like this is how I will think of looking at all X-ray.
Now this black shadow, Dr. Javed, can it be, if not in lung, the way it is behaving, can it be somewhere in mediastinum?
Yeah, it can be either it is herniation from opposite lung, or it can be sometimes from mediastinum, like in esophagus.
So Dr. Avantika, was there any subcutaneous emphysema there at that time?
No, sir.
Okay, fine. So let's proceed.
So during the patient was in ICU, that time an ultrasound chest was done, which was suggestive of bilateral basal consolidation. And with they gave a possibility of right upper lobe large query CPAM or a sequestration, and advised a CT chest. We did a CT chest on day 2 of our admission. So this was suggestive of dense consolidation of the right upper lobe. Right upper lobe, anterior segment, right middle lobe was present, and also consolidation of the left upper lobe and lingular region, and air bronchograms are present in the bilateral lower zones. Suggestive of a infective pathology, very infective pathology.
Please proceed.
Yes, sir. So we did a bronchoscopy. That time the upper airway, epiglottis, and the vocal cord movements were normal. The trachea, there was no compression or any airway malformation. There was no evidence of tracheoesophageal fistula. And bronchus, we only found minimal secretions, but there was significant inflammation and edema of the airways. The samples were sent for gene expert, which was negative. Bacterial culture, there was no growth. On fungal culture, there was Candida auris had grown. The colony count was less than 10^3. Although galactomannan was negative and biofire was also negative. So the patient received IV antibiotics and IV antifungals. The fever had responded, although the cough was still present and retractions were still present. The baby was kept on NIV rams for 20 days and triple HFNC for 5 days. But still the X-ray had shown not much improvement. There was still right upper zone and middle zone consolidation was present with loss of cardiac silhouette on both the sides and hyperinflation present on both the sides with air bronchograms. So since the previous ultrasound that was done was suggestive, they told us that it can be sequestration. So we repeated an CT scan. This time we did a cardiac pulmonary angio. The lung window was suggestive of a similar picture. There was no improvement in the consolidation. This is the CT pulmonary angio. This was suggestive of increased vascularity in the areas of consolidation, but it was not suggestive of any areas of, there was not suggestive of sequestration. And we were advised to get a catheter angiogram done.
Can we go back to the previous, previous slide?
Yes, sir.
Is there anything coming from the vertebral body, from the nerves?
No, sir. There was no evidence of any vascularity from any other, any arteries that was supplying the abnormally to any lung part, and no nerve connections were present.
No. You keep on looking at it, the density, probably like from my computer, the density, what I see on the right side, on the left side, comparing, this density appears a little bit different compared to what I see on the right. This is what I can make out. But are we looking at something coming out from the posterior mediastinum, from the nervous system, something like a ganglion neuroma? Like, is it occupying something, causing compression? Like, because your bronchoscopy was normal.
Yes, sir.
And your child is having tachypnea, probably like the lung is not doing well. You have pneumonic changes on the right lower lobe, left lower lobe too. So like, is there anything else going on, or is it only like lung malformation? Can we have an MRI? Because when I don't have like clear picture with the CT, the next investigation I will definitely look for is an MRI. Is there anything to do with a surgical problem, what we are trying to deal with medically? So once I have a clear cut, like find out like it is not a surgical problem, then I need to go deep into what it is.
Sir, MRI was not done due to affordability issues, and there was no evidence of any ganglioneuroma present, and there was no other compression. It was evident on bronchoscopy and any airway compression from outside.
Dr. Javed, anything that you wish to comment on?
I think one thing is clear that the disease is persistent in the right upper lobe. That means there has to be some local pathology, because even after prolonged antibiotics, this right upper lobe opacity has not resolved. So yes, we need to see whether, although there are no cystic changes per se in this opacity. So again, we need to see whether this is some congenital malformation, number one. And besides, we have to also rule out other causes of non-resolving consolidation. Again, I will go back to basics. We have to find out any defect in immunity, whether this is defect in local immunity or cystic immunity. Local immunity means cystic fibrosis. Should we, whether we have done sweat chloride? I think I'll also evaluate the child since there is failure to thrive. There is involvement of other lobes. So I'll go for sweat chloride testing and maybe for flow cytometry for lymphocyte subset testing, because, you know.
So lymphocyte subset analysis was also done. So that was negative.
So what about sweat chloride?
A lung tap was done for any culture, gram stain, or PCR. Lung tap.
culture-
I think they will be presenting that, sir.
Okay, fine.
So what we have again, epidemiology playing in our minds. What Dr. Javed thinks is what is our, the epidemiology there. If it had come to me, I would probably think of TB first. To Dr. Javed, probably CF first. To Dr. Gauri Shankar, he has thought of differentials which are not so common in our place epidemiologically. So I think let us proceed. Now the picture is 2 more slides, then we'll know what it is. So let's proceed.
The radiologist had advised us for a catheter angiogram, and we could not find any definitive cause of consolidation, and the patient was still having persistent NIV or HFNC requirement. So we had a joint discussion with the pediatric pulmonologist, radiologist, cardiologist, and pathologist, and we decided to proceed with a CT-guided lung biopsy. Sweat chloride was not done because the baby's weight was very less and he was oxygen dependent. So that time we could not do that. And we kept, after all this, we kept a possibility of CF less likely. So this was the lung biopsy. So what we found was very shocking to us. We found these multiple rounded things which were later reported as oil droplets. And the biopsy was reported that there were many frequent fatty or oil droplets amidst the inflammation and granulomatous reaction to the fatty or oil material. There was no caseation. A few bronchioles were identified, but otherwise the inflammation was largely replaced the entire native lung tissue, and the granulomatous response appeared secondary to this fatty or oil material. After having this report, we went back to the mother. We asked. She still denied any history of the same, but we surprisingly that time we got the grandmother, and she admitted that while the mother was away and the baby was with the grandmother during massaging and other occasions, she did use to instill oil in the nose of the baby. So after all this, we kept a diagnosis of exogenous liquid pneumonia with failure to thrive. The baby was given a trial of IV steroids, methylprednisolone, at 10 milligram per kg per day for 5 days. Gradually, the patient was weaned to room air and retractions had reduced, and was discharged after 1 month on oral steroids with advice to stop oil installation in the nose. We have a X-ray that was present at discharge, which is showing significant improvement in the right upper zone consolidation, with improvement also in the left lingular and the lower lobe consolidation with hyperinflation.
I never thought bad child rearing practice can go from south to north to east to west.
So that's why the importance of having so many different experts. I think it has been a learning experience for me also to go through this case. I think I thank Dr. Gauri Shankar for very insightful comments, and Dr. Javed for the Dr. Javed, any final comments?
I think this is really a learning case for us. You know, one thing I skipped, I was about to say, why was oil over rat staining not done?
Yes,
yes.
oil.
So that question is in my mind. Dr. Avantika, did you present the ball cytology?
So lipid-laden macrophages are not done at our place so frequently.
No. Did you present the ball cytology before the lung biopsy?
Ball cytology, no, sir.
That column was missing.
Yes, sir.
So I think all of us should have asked.
One comment, Dr. Kamal here. I would like to put it here.
I'll just come to you, sir. I'll just go. Next is you with us. So Dr. Gauri Shankar, thank you so much. Dr. Javed Iqbal, thank you so much for your very insightful discussion. Thanks a lot. I will now bring in Dr. Parmar Chandane, the mentor and the in charge, for his comments on why he chose the case and what's so what he found challenging.
So I'll tell you what happened in this case. The case. Hello, can you hear me, Dr. Kamal?
Yes, I can, sir. I can hear you.
Yeah. So what happened in this case? No, this case we have involved quite late. Entire case was managed by PSU team. In fact, the bronchoscopy was done by ENT team, not by us. And the ball was sent for investigations and other things. Main thing that was supposed to be done, that is lipid lethal macrophages, were not done. In fact, because that was not the differential that they had kept in their mind. So we were involved actually after the second CT, where they were showing some dense consolidation with some areas which were showing vascularization. So we were thinking, what is this vascularization? And then there was at one point of time there was a discussion between a radiologist, cardiologist, and me about what to do next, whether to do an open lung biopsy, CT guided lung biopsy, versus a cardiac cath, and versus a directly giving the steroids to this child. So the idea was cardiac cath was it was not diagnostic. Whatever vascularization was showing, what I thought at that point of view is probably because of a prolonged consolidation over a period of time, probably leading to some formation of new vessels which were there, which were of no diagnostic value. So cardiac catheterization was deferred because it is not going to add to any diagnostic value to this particular patient. Open versus CT guided morbidity and mortalities were kept in mind, so we decided whether to do a CT guided biopsy. Only thing that was then we may miss something on a CT guided biopsy because the tissue you may get may be very small and may not have a diagnostic value, and we may still have to go in and do a open lung biopsy. That was explained to the parents. Versus giving the steroids, now the finally thing was, अगर कुछ improvement नहीं हो रहा है, तो finally we'll have to come to steroid. That was we were thinking. But without a diagnosis, again, a child who is having for 2 months course, whether to give steroids or not, that was the thing. So here we decided to go do a CT guide biopsy, and thanks to our histopathologist, which actually picked up this oil droplets. Otherwise, we would have been again in the same scenario before doing a biopsy. So we were lucky enough that our histopathologist could pick up these oil droplets, told us what is happening, and then retrospectively we also got some history. There was always a denial thing that they never put an oil in the nose, but after starting the steroids and everything, the child drastically improved. Not that they had followed up after this. After that, they have, again, I don't know where they went off. They not followed. So this was the history. So what I was trying to tell you here is the oil installation is a very common practice, and it has, we have had many cases in the past, especially during less than 1 year. In fact, one of my students who is in the final year now is doing a thesis on exogenous lipoid pneumonias in children, and she has got a sample size of 35 or something. So we will have that case series also, and she has got some 20-25 cases as of now. So it is very common, especially in northern India, but we have in Mumbai, because it has a diaspora of people. We see a lot of people who are coming from south and north, and in Mumbai, and we have seen so many cases of lipodemia. They are fooling us, like typically in children who are less than 6 months or sometimes till 1 year. So yeah.
Good presentation,
Thank you, Dr.
Avantika.
Parmath. Thank you so much. I think this winds up the session today. Just one question to Dr. Gauri Shankar. With these, how long the presentation can go on? Like in this case, 2 months.
Usually 8 to 12 months is the time before the child comes back to normalcy.
Thank you so much, sir. Thank you. I think it has been a very nice presentation. Just 3 words that I would say is: 1, all shadows are not infections. So all radiological shadows do not mean infection. Proceed beyond that. And then again, the sweat chloride is something which can be easily done before very invasive investigation. So if you have that facility, go for it. And in this particular scenario, probably we would have done a BAL again rather than a lung biopsy, because it's so it is for the audience that the case has undergone a lung biopsy, but this is something that we do not do at the first instance, or we do not prefer doing it first. So it is a difficult case which is being presented. That's why it has been done, but it is not a routine. We usually avoid such invasive tests under usual circumstances. So over from me, thank you so much for this nice presentation. And I thank Dr. Modi and Dr. Rawat sir for giving me this opportunity to be here. Thank you so much. Thank you. And it's over from my side. Thank you. Thank you, everybody.
Thank you.
Thank you. Thank you. Thank you.
Thank you, sir.